Recording from the Sunshine City, St. Petersburg, Florida, overlooking beautiful Tampa Bay, this is the Sonography Lounge, sponsored by Gulfcoast Ultrasound Institute. This podcast is dedicated to medical professionals and patients around the world interested in diagnostic and interventional ultrasound. Our podcast will discuss everything ultrasound, from news, trends, career paths, new technology, and industry updates. Hosted by Lori Green and Trisha Reo of Gulfcoast Ultrasound Institute, they bring over 4 decades of experience in the ultrasound profession and are here to guide you through this journey. Now sit back, relax, and enjoy.
Hey everybody, welcome to the Sonography Lounge, sponsored by Gulfcoast Ultrasound Institute, where we talk about everything ultrasound. I'm Lori Green, and I'll be co-hosting today's session with Trisha Reo.
Hi everybody.
In today's episode, we're diving right into thyroid ultrasound and taking a closer look at upcoming changes to the American Thyroid Association's Nodule guidelines, such as what is being changed, what it means to daily scanning, and how it impacts clinical decision-making from detection to follow-up.
Yep, and we're so excited to have with us in the Sonography Lounge today Dr. Jennifer Sipos. She's a nationally recognized expert in thyroid disease and endocrine oncology at The Ohio State University. She is one of the experts who is helping define the guidelines changes and has been involved in this process for multiple years, contributing to a more flexible, evidence-based approach to thyroid nodule management. So welcome, Dr. Sipos.
Thank you so much for having me. It's really a pleasure to be here.
Absolutely.
Awesome.
Well, we'll dive right in.
Let's do it.
Yeah.
Right? So, Dr. Sipos, why don't you just share with us why we need another ultrasound thyroid nodule stratification system when we already have the ACR TIRADS and the 2016 ATA system?
Yeah, that's a really important question and one that we are asked very frequently as we talk about these new guidelines. So as you've mentioned, there are several sonographic stratification systems that are currently in use in the US, but there are also systems worldwide that are in use as well. And which system is used is really dependent upon a couple of factors. One, what your practice specialty is. So radiologists tend to use ACR TIRADS or American College of Radiology TIRADS system. And then endocrinologists tend to use ATA and ACR TIRADS. And also geography matters. You know, in the US, we're primarily using ATA and ACR TIRADS, but in Europe, they use European TIRADS, and in Korea, they use the Korean TIRADS, as you would expect. And each of these systems, they perform pretty well in identifying cancerous nodules and benign nodules. And really, their diagnostic performance is driven mostly by the FNA size cutoffs that are used for each system. And so that really drives the sensitivity and specificity of each of these individual sonographic stratification systems. But we know that all of the systems have limitations, and those have been well described, well documented by the literature, and several well-performed studies have shown what those limitations are. And the biggest issue that folks have brought up with the American Thyroid Association system from 2016 is that not all nodules are classifiable. Up to 20% of nodules are not classifiable with that previous system. And that's really, disconcerting, and especially as a clinician trying to decide how do we really manage these nodules if we can't even classify them. Mm-hmm. Fortunately, most of the time it's a little bit lower incidence of this, but you're going to encounter it if you see enough nodules. So we really wanted to address that major glaring issue. And so that was one of the main reasons that we really wanted to try to create a new system. We also wanted to really drive the development of this system using the current literature. So updating a system using more recent data that have come out since ACR TIRADS in 2017 and the ATA system in 2016. And so that's going to really drive a lot of the changes that you see in this system compared to the 2016 version. And so that was just another issue that we really spent a lot of time discussing as a group. We know that radiologists are going to continue to use ACR TIRADS, and that's okay. It's a fabulous system and it works great, but we still think it's important that we update it because there are a number of things that ACR TIRADS don't address. And the first of which is that ACR TIRADS is really only meant for individuals who are low risk. And what I mean by that is they don't have a family history of thyroid cancer, no personal history of radiation exposure. It doesn't apply to PET positive nodules. It doesn't apply to previously biopsied nodules. And a lot of providers don't realize that. It's really only meant for the initial evaluation of a nodule. So the ATA system really allows us to stratify nodules for all patients. And those patients for whom maybe have any one of these features, they're probably going to be seeing maybe a thyroid specialist, whether that be an endocrinologist or a thyroid surgeon. And they're more likely to use an ATA system than a radiologist who would be using ACR TIRADS. So we think there is still a place for a new system to address those previous limitations that the ATA system had, also allowing for more updated literature evaluation, inclusion, and then really capturing all patients using this new system, as opposed to what the ACR is really not designed to deal with that. And then another reason I think that the ATA system is beneficial is the risk of malignancy for some of the point allotments that have been given to ACR TIRADS may not reflect the more recent published literature. So, those 3 points for punctate echogenic foci or 2 points for a macrocalcification, maybe those risk assignments are not necessarily proportional to what more recent data have shown. So for a good example, a solid hypoechoic nodule with no other suspicious features, it's classified as TIRADS 4, and the risk of malignancy is anywhere from 5 to 20%, averaging around 9%. But more recent literature suggests the risk of malignancy of that lesion is probably higher, so as high as 27 or 37%. So we felt that it was important, again, to update and using more recent literature to sort of drive our clinical decision making and using this new system. And then the final limitation, I think, of ACR TIRADS, and the reason that we felt it was important to create a new system, is that radiologists with a non-subspecialty in thyroid disorders or those with less experience are more common. It's more common for them to assign higher risk scores to those nodules. And that can that can translate to higher rates of unnecessary FNAs. And this is especially true in partially cystic nodules. I think those of us who see these patients will all agree that it's not at all uncommon for us to be referred a patient with just a plain old spongiform nodule, but it comes to us labeled as TIRADS 5 because maybe it has punctate echogenic foci in there and it's hypoechoic. And so those points can rapidly add up and create a higher risk profile for a nodule that's not necessarily true clinically. We can look at that nodule, see its spongiform, and recognize that it has a very low risk for malignancy. So our system was really designed to help mitigate the risk of those overcalls that we can commonly see in TIRADS classified nodules. And so we are hopeful that by the way that we created this algorithm for defining nodule risk will limit the potential for over-assigning risk to a nodule, especially a partially cystic or even a spongiform nodule.
Wow, that's a great breakdown.
Yeah, absolutely.
I feel like some of the points you were making, the differentiation really comes between somebody being seen in like a radiology department where it's just, being interpreted by a radiologist, like you said, and they're going to apply those TIRADS versus potentially being performed in a specialist office. So they're going to be a little bit more specific with those guidelines and have a more comprehensive or thorough or desire for a more comprehensive or thorough evaluation and a stratification system. So that makes total sense. Do you, as a side question to that, do you foresee a lot of radiologists adopting this, or do you think this will be more adopted by the specialists and the radiologists will stick with that TI-RADS?
Well, I suspect that radiologists will continue to use TI-RADS, but there will be probably an updated version of TI-RADS that they'll end up adopting. And I know, in having spoken with Dr. Tesler, who was one of the main authors on the ACR TI-RADS publication, they are working to sort of iron out some of the details for that updated system. And my expectation is that it will have different point allotments, again, updated with the current literature. So I suspect they'll continue to use ACR TI-RADS. And I think there's place for both.
Right.
I don't think, it has to all be one. Yeah. And to be fair, I don't want to paint radiologists as the bad guys here.
No.
Their role is very, very important in evaluating these nodules and getting them into the hands of folks who specialize in this. And from their perspective, I can completely understand the desire to, or maybe the tendency, is a better word, the tendency to say, you know what, if I'm not sure, I'm gonna say this is maybe higher risk, because from their perspective, they don't know if this patient is going to come back. They don't know that this patient is going to have further evaluation. So if they're leaning toward undercalling something, that has the potential for missing something.
Yeah.
Whereas if they're sending more stuff on and escalating it, then it gets evaluated by the specialist, who can then say, okay, no, this actually looks lower risk. So when I talk to patients about it, I specifically say that, like, look, I'm not faulting the radiologist here at all. I think it's important what they're doing, and from their perspective, they're not sure if this person's ever going to come back or get further evaluation. So I'd rather err on the side of caution there. And so I think, another reason that we created this system is when a patient comes to me with what's labeled as a TI-RADS 5 nodule, and I look at it and I say, this thing's spongiform, it's benign. Not only does it not need a biopsy, but you really don't need follow-up of this thing. I mean, that's a huge difference.
Oh, yeah.
If the patient gets on the internet and reads TI-RADS 5 and they see the risk of malignancy associated with that. And so we created the ATA system to sort of better allow for providers to sort of bridge that gap and say, this is why this is not a high risk nodule, and to better give us a footing as the one who's coming in and saying, no, that's completely wrong, and it's the complete opposite of what you were told. So that's also kind of built into the system to give clinicians that footing to say confidently, this is not a high risk nodule.
Yeah, that's great for patient peace of mind too, because I know
who are they going to believe?
I know exactly.
I'm not I'm technically not a radiologist. I just play on TV, but and so for the patient to say, well, this is a radiologist and they're saying this, but you're not a radiologist and you're telling me it's not that. Like, who are you? I can understand it from the patient's perspective as well.
And with so much available online now. I mean, the first thing you do is you go on. I'm guilty of it myself.
Yeah, we were just talking
about something else that I had, and I'm like, I wasn't sure what that was, so I Googled that, and I was like, ooh, I'm not so happy with that. So people will definitely get online and try to figure out, how serious does this sound. So being able to go to a specialist and have them outline, yes, that's a great way to initially evaluate it, but this really takes it a step further, and we can confidently say yes or no that this does need a biopsy or doesn't. So that's huge. I really I think that's a great place for these guidelines to get updated, and probably the ACR will try to update theirs as well to be a little bit more in alignment, so that everybody's on the same page.
They're actively working on that, and they're working on the validation phase of what they've created, and so I expect we'll see something from them soon.
Well, and they have all your wonderful research to base that on. So
exactly.
That's who you are. You're the pro. You're the pro. I also think it's an important distinction for sonographers, because if you're somebody who's working in a radiology department and you have your radiologist interpreting it using the TI-RADS system, versus maybe you also work part-time in a clinic scanning for an endocrinologist and they're using a completely separate system. There's overlap, yes, we just talked about that, but it's nice for the person taking the images to have an idea of how what they're measuring or what they're imaging or what they should or shouldn't do protocol-wise will fall into those guidelines. Yeah. So we've kind of talked a little bit about, the specific, exactly what you wanted to address with the new guideline updates. We've kind of just hit on that throughout it. But can you maybe lay out a description of the new stratification system, just, a brief overview of what people can expect to come out of this?
Yeah. I think that's... It can be a little daunting, and as a visual learner, I like to be able to see the sort of big picture, and then I can process the auditory component of it. But it's sort of in a nutshell what we're looking at. The 2016 guidelines were based on a sort of a pattern recognition system, and that was designed specifically to allow the clinician at the bedside to rapidly make an assessment of a nodule. Once they've memorized the different patterns of a nodule, they could just kind of in their mind go, okay, this one falls into high or intermediate low. So it's just a rapid recognition. Whereas with ACR TIRADS, it's the points. So you have to not only memorize the point allotments, but you also have to sort of keep a running tab. Some of us are better at math than others. So, it's maybe a little bit more, not difficult to use, but it's not as rapid to use ACR TIRADS as it is ATA. However, the knock, as I said, on the ATA system is that not all nodules are classifiable, and we don't want to try to classify all nodules using a pattern-based system. It would be impossible to memorize every type or even to describe every type of nodule that exists. So it's, instead of taking that pattern-based approach, we're shifting gears and we're using an algorithmic approach. And so we are just making a paradigm shift. And this will allow us to categorize all nodules in a way that still remains user-friendly. We know that nodules there's a big difference in risk of malignancy based on whether it's solid or cystic. And so that's really the first sort of differentiating point in the algorithm, is to determine the nodule's composition. So we have nodules that are solid, and our definition of a solid nodule is greater than 90% solid composition. And then the opposite would be cystic. If it's more than 10% cystic, it's considered to be cystic. So that's a little bit different than what we maybe intuitively would think about a cystic nodule.
Right. Yeah.
But that's where we drew those lines based on the literature. And then there are a small category of nodules that we can't assess the composition. And we've all seen these nodules where they have a coarse calcification that obscures our ability to see behind that coarse calcification. So the more common ones are those eggshell calcifications that we see, a nice thin rim of calcification, but you can't see the inside of the nodule. But there are also nodules that have a sort of a exterior a peripheral calcification that's maybe coarse. So we lumped those types of nodules into the we cannot assess category. So it's going to be a minority of the nodules that are going to fall into that category. But we also included those because they were not classifiable with the previous ATA system. So once you've sort of gotten the composition of the nodule assessed, we'll sort of talk about each of the three arms. Within the solid nodules, they're then further divided based on their echogenicity. So are they markedly hypoechoic, as in darker or as dark as the surrounding musculature? And then another category is just regular old hypoechoic. So it's darker than normal thyroid parenchyma, but not as dark as the skeletal muscles. And then iso and hyperechoic are lumped together. If a nodule has mixed echogenicity, it's considered just run-of-the-mill hypoechoic. So if it's got some hyperechoic areas and hypoechoic, we put it into hypoechoic. And so within the solid nodules, all three categories of echogenicity, we then count up the suspicious features. And we call these suspicious features solid nodule suspicious features, or SSF. So we're specifically saying solid nodule suspicious features rather than just suspicious features, because they're only assigned to solid nodules.
Okay.
We do not assign those risk factors to cystic nodules. And that's how we're mitigating that risk of overcalling cystic nodules, like a spongiform nodule that has some echogenic foci in it. So that's how we are trying to mitigate that risk of overcalls. So the solid nodule suspicious features, there's 4 of them. So one of them is a taller than wide shape. Another is punctate echogenic foci. We're not calling them microcalcifications anymore because they don't always histologically correspond with calcifications on surgical path. And then we have macrocalcifications. And then the 4th one is irregular margins, so that infiltrative margin, or, and this is new, an irregular halo. So we kind of ignored halos before with all the other systems. We don't really address them. We have found in the literature that if the halo, that sonolucent rim around the nodule, if it's irregular, it's thicker in some areas than others, then that has a higher risk of a neoplasm, a higher risk of malignancy. So we've included that in this. So it's either an irregular halo or an irregular margin is that 4th feature. And so again, those are only applied to solid nodules. And so we count up the number of those features that are present. And then depending on the echogenicity, if it's markedly hypoechoic with 1 feature, it's considered high risk. With no features, then it's considered intermediate risk, and so on. And that's where it gets a little complex, and it's helpful to see the algorithm on paper.
Right.
But as I was saying before we came on, we do have an app that providers can use to plug in, okay, what's the composition? And you say solid, and then it goes to the next screen and it says, what's the echogenicity? You say hypoechoic, and then you go to the next screen and it says, what features are present? And you click all the features that are present, and then it pops up with a risk score. So this is an intermediate risk nodule, and then it also gives you the size threshold for FNA. Which is really nice. So it's right there on your phone. Most of us have our phones when we're seeing patients, unfortunately, but it's also available on desktop. So providers can use that to score the nodule. So that's all the solid nodules. And then the cystic nodules, those kind of come in a couple different flavors. So we have partially cystic nodules, we have spongiform nodules, and then we have pure cysts. Pure cysts, still benign. It's the same as the last set of guidelines. Spongiform nodules, those are still, vast majority of them are considered to be very low risk. However, we added another category of spongiform nodules because there are a couple of studies suggesting maybe a slightly higher risk of malignancy in spongiform nodules that have either a macrocalcification or an irregular rim, peripheral rim, or if they have an irregular halo. But that's only applicable to nodules that have not been aspirated, because we know that spongiform nodules that have been aspirated can develop calcifications. So that has to be a previously unaspirated nodule. So those are now considered low risk instead of very low risk. There are not a lot of studies looking at this, and we suspect it's probably not truly an increase in risk, but we'd rather overcall it than undercall it.
Yeah.
And then in the partially cystic nodules, that's probably going to be the most nodules that we see in this category. There's really only 2 categories, high risk and low risk. There's no intermediate risk. High risk is the classic cystic papillary thyroid cancer. Not many nodules are going to look like this at all. Most of the nodules are going to be the low risk partially cystic nodules. And then for the 3rd category of composition, we can't assess. There are three categories there in terms of risk: high, intermediate, and low. The low risk is the eggshell calcification. Those are going to be the most common ones. And then the intermediate risk is a coarse calcification, just period. And then the high risk is a coarse calcification with a soft tissue protrusion through that coarse calcification. And those are going to be fairly uncommon, but we did want to be able to classify those.
Classify everything.
Yeah,
That's
like it.
right.
Yeah.
That's the theme.
Yep.
Yeah. Well, no, I think
Well,
it'll give
I
a
think
lot of
that's
direction.
great. Yeah, no, it's going to make the decision making a lot more complete and accurate and
Consistent.
right, across the board.
Yeah.
So
I think
That's
it's
our
going to be a
hope.
great system.
Yeah, we're eager to do a multi-institutional study to analyze how it performs. So we're on the early phases of planning for that.
that's fantastic. And I love the app idea. I mean, that's going to
Yeah.
just be a game changer for the clinicians to be able to put that information in. And
So
you know.
user friendly, and it has both images, like sonographic examples of the nodule, and cartoons, depending on kind of how you like to think about things. So
It'd be fun.
and then the recommendations for FNA is really great.
well, I would imagine that in the process of establishing the new guidelines and all these different categorizations of that, would that information lead to changes in the patient management and what you would do next and that sort of thing? Now that we have a little more information.
Yeah, we definitely, once we have determined whether or not to perform an FNA, we have spent a lot of time sort of discussing, well, what next? And one of the biggest questions that comes up when I'm, giving a talk is, how long do you follow thyroid nodules? When can we stop following these things? We know malignant transformation is not an issue with the thyroid nodules, going from benign to cancerous. So do we really have to follow these things forever? And so we really wanted to address this issue. And this is probably my favorite guideline in the entire document. But we determined that if a nodule is not high risk sonographically, and the patient doesn't have high risk personal features, so they haven't been radiated as a child, they don't have a family history of thyroid cancer, and a benign FNA. So again, this is not a high suspicion nodule. This is intermediate and below with a benign FNA. In the absence of suspicious concerning risk factors for the patient, we can stop performing surveillance ultrasounds for malignancy detection after 5 years. And so that is really a game changer for clinicians, because we've all seen these patients, or you've scanned these patients and you ask them how long they've had these nodules, and they're like, oh yeah, I've been following this thing with annual ultrasounds for 20 years, and it's just like, oh my word, what are we after here? So we really felt it was really important to address that. And then we also went a step further. So that's, for nodules that have had a benign FNA. If the nodule falls below the size threshold for FNA and it's been surveilled for 5 years and it has not had a change in size or sonographic appearance for 5 years, it's not high risk on ultrasound, then we do not need to continue to surveil that nodule as well. I think these are truly, as I said, game changers for us as providers and for our patients who are constantly being gelled up.
They love it.
As long as it's warm.
Yeah, exactly.
As long as the gel's warm. Yeah. No,
I tell them it's anti-wrinkle cream, and that does help with they're not binding as much.
It is hydrating, so you're not lying.
Yeah,
it might be stretching the truth a little bit, but it's hydrating, right?
Exactly.
Well, and I think that's the difference between not the hydrating gel, the follow-up. I think that's the difference between having confidence in what your physician's telling you as far as what they're seeing, and having low confidence, right? So if you're being followed up every year for 20 years and it's the same thing, at some point the patient starts to wonder, why am I doing this? Why do we keep looking at the same thing if it's always the same answer? Is it really bad, or are we just doing unnecessary exams? So I think having a stratification system that gives not only the clinician more confidence in their decision to either follow up or not follow up, but it also gives that patient a little bit more peace of mind, because they're going to Google it. And this is going to come up.
And there's going to be some level of anxiety for the patient every time they got to go
Right.
and have this follow-up and,
Yeah.
praying, oh God,
Yeah.
I hope this
And,
doesn't show any
and if you're
changes.
following it up and nothing's ever changing, you start to wonder, well, do we even know what we're doing here? Or are we just doing this because for lack of knowing what to do?
Right.
So I think having that stratification system will give everybody a little bit more confidence and peace of mind.
Yeah. And I think, from the patient's perspective, and I've tried for years to try to convince patients, I don't really think they need to continue to have sonographic follow-up of these nodules, even before these guidelines kind of came out saying what we already kind of knew clinically. Patients are still scared that these things are going to turn into cancer. And when I tell them that they don't turn into cancer, then they're like, oh, okay, I'm good.
I'm good.
It's really just making sure they understand that, because it is a growth, and unless you're a scientist, you're not going to really think about that. But just growth, and you think cancer. So understanding, and I just tell patients, look, cancers grow, and this thing hasn't changed in 10 years. It's not a cancer, and it's not going to become a cancer. Then they're like, okay, I'm all right without being followed. But it's that. Well, I got to make sure it hasn't turned into cancer kind of thing. And so, and I don't know if a lot of providers even think about that or know that. But that's the missing piece, I think, of the puzzle there is, it's not going to turn into cancer.
Well, and that's a part of ultrasound that sometimes lends itself to abuse, if that's the right word to describe that, but because it's
overuse.
Yeah, overuse would be a better word for that. But it doesn't have any radiation. It's not invasive. It's relatively cost effective. It's low cost to the patient typically. So they don't think much about, well, we'll just do another ultrasound. We'll just order another ultrasound. Especially if that patient's nervous. I feel like the primary care doctor's like, well, that's outside my realm of expertise. Let's just order an ultrasound so that you have peace of mind that it's okay.
That's okay.
Yeah, you're absolutely right. On all of those points.
Yeah.
Yeah.
Well, we're going to kind of change directions here. So there's been a lot in the press about those GLP-1s. We all have heard all sorts of things about those GLP-1s, and more recently, they've started discussing the association with thyroid cancer. So should we consider screening ultrasound in patients who are considering starting one of these medications?
Yeah, that's, just a really a great question, and something that we really felt strongly we needed to address. As far as I'm aware, no other guidelines have really discussed this particular issue. So, we did a deep dive on the literature looking at this. For those who are maybe less familiar with these drugs, they have been, there's been an association, and there is currently a black box warning by the FDA for concerns for development of medullary thyroid cancer in those who are taking GLP-1 receptor agonists, or making sure that they don't have a history of medullary thyroid cancer or a family history of medullary thyroid cancer. And it's all over the TV commercials as well, saying, if you or a family member has medullary, contact your physician, or you may not be a candidate, whatever the verbiage is. Really where this derives, this concern derives, is in early preclinical studies in mice, who the mice were exposed to high doses of GLP-1 receptor agonist drugs from birth to death. And they found an increased incidence in these mice of developing medullary thyroid cancer. And so certainly of concern, but to prove that it was in fact the GLP-1 receptor that was causing this and not some other factor, they performed studies in mice for which the GLP-1 receptor was taken out. So they developed a genetic model of a mouse that did not have a GLP-1 receptor, and then they exposed them to the drugs, the GLP-1 receptor agonists, and saw whether or not they developed medullary thyroid cancer. And they did not develop medullary thyroid cancer. They did not develop C-cell hyperplasia, which is sort of the precursor to medullary thyroid cancer. And they did not demonstrate high levels of calcitonin, which is sort of the tumor marker that can be predictive of having medullary thyroid cancer. So certainly concerning, and points to the fact that it is indeed the GLP-1 receptor in mice that drives development of medullary thyroid cancer when exposed to these drugs. So humans are not mice, as we know, and we need to understand whether or not humans are at risk for this when taking these drugs. And so these studies were performed in monkeys, which obviously are more closely genetically related to humans. And they found that when they exposed monkeys to high doses of GLP-1 receptor agonists, they did not develop C-cell hyperplasia, again, the precursor to medullary thyroid cancer, and they did not develop high levels of calcitonin, or the tumor marker that can predict medullary thyroid cancer. So the monkeys didn't develop medullary thyroid cancer when exposed to these drugs. So a little more reassuring for us as humans, but why is there such a marked difference between mice and monkeys, other than they're not the same animal? And the answer lies in the fact that mice have much, much, much higher concentrations of C cells than humans and monkeys within their thyroid. So the C cell is a specific type of thyroid cell that is responsible for creating medullary thyroid cancer. When mutations occur, that turns into medullary thyroid cancer. So humans have a very low concentration, as do monkeys, of C cells in their thyroid. So humans probably are at a much lower risk of developing medullary thyroid cancer, but because of this data, the FDA felt very strongly that, there needed to be sort of a warning that there could be a theoretical risk of developing medullary thyroid cancer when exposed to GLP-1 receptor agonists for any length of time. And because of that, they've also created sort of a reporting system for clinicians when a patient develops medullary thyroid cancer if they're on a drug, a GLP-1 receptor agonist. To my knowledge, there have not been any definitive cases that have been reported where there's clear-cut evidence that this person developed medullary because of the drug, but that can be hard to prove. But many of us feel very strongly, based on the fact that there's just not really an increase or an uptick in the number of medullary thyroid cancer cases that are being reported, that this is necessarily an increase in risk for humans. But nonetheless, patients should be advised that if they are taking a GLP-1, or if they are being considered for a GLP-1 receptor agonist, they should not use it if they have a personal or family history of medullary thyroid cancer. For our guidelines, based on the literature that exists, we did not feel that there was enough of a risk to humans to warrant screening ultrasound in patients who are being considered for GLP-1 receptor agonist therapy. So as such, we said that there is no need to perform. We recommend against screening ultrasound prior to starting a GLP-1 receptor agonist in a patient who is a candidate for the drug, i.e. no personal or family history of medullary thyroid cancer. Okay. We also recommended against screening calcitonin levels in those patients. Many people, especially in Europe, talk about using calcitonin as a good screening test to detect medullary thyroid cancer in patients with thyroid nodules, because medullary can be difficult to diagnose on biopsy. But you get a lot of false positives with calcitonin measurement. And so we did not feel that the data were strong enough to support measuring serum calcitonins before starting the drug or during treatment, because you can get a lot of false positive readings with that. And we took it a step further as well. In patients who have a known nodule, whether it's been aspirated or not, they are still candidates for a GLP-1 receptor agonist therapy. They do not require an FNA prior to starting therapy unless the nodule warrants it. But just because they're starting a GLP-1 receptor agonist, they do not need aspiration of that nodule, as long as there's no personal or family history of medullary thyroid cancer.
Mm-hmm.
Awesome.
Very interesting.
Clarified that.
Yeah.
Those warnings can be scary.
I know.
And for some patients, the GLP-1 may be their last option to manage their diabetes and obesity. And
Yeah, life-saving drugs.
Exactly.
And, to preclude someone from getting it because of a theoretical, even weakly theoretical risk
Right.
of a cancer is really just not fair.
Yeah. I think our
Yeah.
listeners who maybe are non-medical, we have quite a few people who tune in and just listen because they enjoy our show, because we're
Yeah.
fun. But I
We're a
think
lot
that
of
those
fun.
patients will appreciate that information because, again, those warnings can be very scary. And when you're trying to make a decision about a medication that could positively impact your life when it comes to managing your symptoms, it would be nice to not have to
Yeah.
overthink that one.
Right.
Yeah, and
Absolutely.
there are a couple of studies out there, kind of as an aside or a tangential here, that suggest an increase in the risk of all thyroid cancers in patients who are taking these drugs. And so, for the particularly savvy patient or provider who's really good at reading the literature, and because it has gotten a little bit of attention and even maybe some of the lay press, there was particularly a French insurance claims database study that was done about 3 or 4 years ago, that suggested there was an increase in the number of all types of thyroid cancers in patients who are on GLP-1 receptor agonists compared to second-line diabetes meds. So that got a fair bit of attention, as you would expect, because that's certainly disconcerting, and in any type of cancer, but thyroid cancer maybe being a little less concerning, but still, if you hear the C word and associated with your own health, it's scary.
Right.
That study, again, was looking at insurance claims, and it's with database studies like that, you really have to carefully look at the data to make sure it's truly applicable and you're not just detecting a bias. In this study, what they showed for patients with all types of thyroid cancers, and in particular differentiated thyroid cancers, so papillary and follicular thyroid cancers, they saw there was indeed an increased signal of or detection of thyroid cancers in patients on GLP-1 receptor agonists compared to second-line diabetes meds at all time points across the continuum of the study. So in those who were exposed to drug for less than a year, 1 to 3 years, or over 3 years. And that rate of thyroid cancer was higher and statistically significant compared to their peers. The problem with that study is that if you are seeing an increase in the rate of a disease that quickly after starting a drug, that makes me think that's probably, especially a tumor, tumors take time to develop, and a slow growing tumor like thyroid cancer, for it to develop in less than a year seems pretty unlikely, with what we know about tumorigenesis of thyroid cancers. So for us to see an increase in signal, just less than those folks who are on drug for less than a year, suggests there's a bias in there, and it's probably detection bias. And they saw across all time points the magnitude of the increase in rate was similar. So it was just like a step up and it stayed stable. It was similar across all the time continuum, and that really just doesn't jive with what we understand about tumorigenesis, suggesting that there's probably some detection bias. And we know that the people who probably were picking up those thyroid cancers were probably endocrinologists, and they're aware of these mice studies suggesting increased rates of thyroid cancer, medullary thyroid cancer. So trying to sort of beat it to the punch, maybe doing screening ultrasounds. And we know thyroid cancer is prevalent in our society, and in the US, up to 12% of people have thyroid cancers that they'll die with, not from. So if we go looking for thyroid cancers, as you all know, we will find them. And so that's probably what that increased signal is in that insurance claims database, and probably not a true increase in the incidence of thyroid cancer. And the European version of the FDA really took a careful look at this because it was performed in France, and they determined that there was nothing to it. There's not truly an association with differentiated thyroid cancer and these GLP-1 receptor agonist drugs. So, patients will ask, and we certainly talk about it pretty frequently in clinic, but I do not believe there is any association with differentiated thyroid cancer and GLP-1 receptor agonists.
Well, thanks for explaining all that.
Yes, very useful information.
More than you ever wanted to know.
Well, but not.
Yeah, really.
Again, it comes down to if you're told you need something, a specific medication, and it's going to help you, and yet your primary care doctor is, as you said, savvy with the literature and brings this stuff to you, you're like, oh, great. So now I have an option for a medication, but I'm going to be at an increased risk of thyroid cancer. Mm-hmm. Lovely. Yeah. But I think it's really good to get that information out there so that, again, providers can be more knowledgeable and help their patients make decisions as to what is the right path for me to take. And obviously knowing, okay, I have a family history of medullary cancer, well, maybe this is not going to be the best option for me. That's also helpful. So,
and it's all out there, every ad and promo and this company against this company and that, and, do you really want to put yourself at risk? And so, the patient that's thinking about it, that is a concern for them. So that's really good to have that. That's a very thorough discussion on that, which I think people will find very helpful.
Well, and I also think it's helpful for maybe the people who are using it out of convenience rather than out of necessity. Mm-hmm. We do hear a lot of people are using those GLP-1s for just generalized weight loss when that's not necessarily the path they need to go. It's just the easy button. Mm-hmm. But there's risks, and again, understanding those risks and being informed is important.
Right.
So,
yeah,
absolutely. Good stuff.
So I guess we're to a point, we're starting to get close to time, but if you'd like to touch base on, what you're part of this whole guideline development. So, what will remain the same with the proposed guidelines compared to the earlier versions, and as far as that goes?
Yeah, there are a couple of things, not huge issues that really remain the same, but we still are recommending that a serum TSH be measured in all patients who have a newly identified thyroid nodule to sort of help us discern whether or not an ultrasound is the next step or an radioiodine uptake and scan. And also to sort of stratify risk of malignancy. Toxic nodules are very unlikely to harbor a malignancy. We also are still recommending that a TSH should be measured 6 to 8 weeks after surgery if a patient does have surgery for their thyroid nodule. And now we're using a lot more lobectomies, and the hope is that patients won't necessarily need levothyroxine supplementation, but if they do need to be assessed to determine whether they do. We also are still recommending that if a patient has had 2 benign FNAs, not a lot of folks fall into this category, but we all sort of see this occasionally where a patient, especially someone with a long-standing nodule, and if they've had 2 benign FNAs on the same nodule, ongoing surveillance for detection of missed malignancy is no longer necessary. So that used to be my favorite guideline, and now we don't have to follow them for more than 5 years. It's my favorite guideline. So those are the main things that kind of remain unchanged.
Awesome.
Okay. Well, that all makes sense.
Good information. That does make sense.
Yeah, that seems very appropriate.
Yeah.
All right. Well, overall, it sounds to me like the new guidelines are about doing less overall, but making sure that what we are doing, we're doing better. So better understanding what we're seeing, better classification, better follow-up, and then better decision-making, what needs to be followed up, what doesn't need to be followed up. So it's just about improving the overall care for the patient, which is always a good thing. We're going to rely more on this risk-based stratification, raise those biopsy thresholds, as you mentioned, and shift toward more active surveillance in situations where it's needed, but it's based on the individual patient. So I can't see how that can't be a positive change for everybody. So That's awesome.
Positive mood.
Yeah, all positive changes. So I look forward to the new guidelines, and hopefully, we've heard some word, October-ish of 2026, maybe. We'll be looking for those guidelines. And guys, we'll make sure to put those updates in the show notes for you guys once they are published. And then, of course, we have our course coming up.
Yes, we do.
Which is going to be in November. So please make sure that you check that out on our website, because we will have Dr. Sipos here in person with us to go through, not only how to classify these nodules on ultrasound, but how to perform thyroid ultrasound and how to look at the various disease processes and how those will look sonographically on ultrasound, and be able to work more closely with her to look at that new stratification system. And then we'll also have a dedicated hands-on scanning workshop during that, where you'll get to go into the lab and work with our team of expert sonographers as well as with Dr. Sipos. So we hope you guys join us for that in November. Check out our website for more information on that.
Yeah, absolutely. We're excited about having that course and having Dr. Sipos here. And so put that on your calendar, people. Come down and see us.
Sunny Florida in November.
November is a great time to come to Florida. So
Absolutely. Much better than Ohio.
Yeah, it's starting to get a little chilly there in November, right?
Yeah.
Still chilly right now.
Oh,
no,
man.
sir.
Oh, wow. Well, June's right around the corner. So
It was 88 here yesterday, so
yeah.
I don't know that I want it to be that warm already, but here we are.
Yeah. But it's been great. So, well, we are about out of time here now. So I want to thank Dr. Sipos for joining us and sharing your insights and your expertise in the field, but also, as someone who has helped shape the guidelines that we're all working from. And it's conversations like this that really help to bridge the gap between recommendations and real world practice. So I'm sure all of our listeners here have gained a lot of information from this discussion itself, and hopefully we'll be looking forward to seeing the guidelines and starting to integrate those into their clinical practice at that time as well.
Yeah, that'll be exciting.
All right.
And, for our listeners, whether you're interpreting, scanning, or you're a clinician who is using these guidelines to drive your patient care, you all impact the whole process together. So we really appreciate you taking the time to listen to this episode, to implement the changes that are being discussed here. We look forward to you asking questions and digging deeper and just trying to utilize this information to improve your overall patient care. And of course, we always appreciate the fact that you guys tune in and you're faithful followers of our podcast, our little passion project here. Yep. We are coming up on our 5th birthday, so we'll be celebrating that here soon as well. So 5 years of podcasting fun with Lori.
Yes.
All right. So thank you all for tuning in as always. Thank you, Dr. Sipos. We really appreciate you being here with us. And happy scanning.
That's right. Thank you, everyone.
Thanks for listening to the Sonography Lounge. Don't forget, if you like this episode, please subscribe and leave us a review on iTunes, Spotify, or wherever you get your podcasts. You can also find us on Instagram at Sonography Lounge and Twitter at SonographyLNG. If you have any questions, comments, or topic suggestions, feel free to send an email to us at sonographylounge@gmail.com. Have a great week and scan, scan, scan.